We shall be getting into our session proper, but first is a recap of what we did last week. Basically, last week we were on episode 9, and we're tackling aspects to do with the neonatal lung. And really, it was an explosive session. There are two pediatricians alongside a senior resident taking us through aspects to do with the care of babies in the ICU. And basically the take home was that babies are not exactly small adults. They are definitely different, and their physiology is so unique that you need to have a broad differential for so many things. So many things get added to the usual physiological and pathological things that we see in the adults. And their physiology being immature, right from the cardiorespiratory to renal to hepatic, to immunological, presents quite a unique challenge to their care. Overall, we learned that time is of the essence, taking care of these babies because their physiological reserve being limited, and therefore understand their physiology so we can tailor treatment properly, be very useful. The session is available on the YouTube channel for AAU, and I encourage those who have not been following to catch up with the previous recordings so that you might be able to follow where we are now and where we're going next. So today we are crossing over to interactions between the lung and different organs in health and disease, and specifically to understand how lung disease can influence other organs and how other organs can influence the lung when they are not well. So we dubbed it the pulmonary organ Higgy Hagga. These presenters are a bit unique in that each presenter has got a specific mentor who guided them in developing the talk and will be in the background listening in, and will hopefully respond to the different questions. I'll be moderating this alongside Dr. Cornelius as usual. And as usual, our rules are that we should stay muted, share questions in the chat, and raise our hands when the question and answer session is launched. So right away, I'd like us to move to the first speaker of the day. That's Dr. Dixon, who is a senior resident, emergency medicine at Makerere University. He is going to take us through the interactions between the heart and the lung. He was mentored by Dr. Cornelius Sendagire. So Dr., kindly share your slides and start right away. Yep.
Yeah, all right. Good evening, everyone. Just let me get my slides up. I hope you can see them.
Yes, we can see your slides and we can hear you clearly, Doctor.
All right, that's great. I'll just put it in presenter mode. Yeah, all right. Good evening, everyone. My name is Dixon Kamoga, and just like Dr. Rasmus said, I'm an emergency medicine resident, currently in third year. And yeah, first off, I would like to thank Dr. Rasmus and Dr. Cornelius for always putting these sessions together and ensuring that all of us in emergency medicine, anesthesia, and critical care get this time, to interact and learn about the different things in the field of medicine that we practice. And lung pendulum. This is kind of a weird way that topic is named, and I presume everyone who looked at the poster before the presentation today wondered what this actually means. But I believe at the end of this presentation, you will know how the different interactions of the heart and the lungs sort of make it function like a pendulum. So what we're looking at, is the heart being together with the lungs in the same chest cavity, and serving different functions, where the heart is simply pumping blood to the rest of the body parts and the lungs are receiving air and pumping it out, and just letting gaseous exchange happen. So I'd like you to imagine it this way. So when initially the lungs are relaxing, and getting air into them. So the chest cavity is moving out and blood is returning to the heart. So the heart is just simply tagging along the direction in which the lungs are, are moving. So the lungs are expanding during inspiration, and the heart is just basically tagging along to the direction of movement of the lungs. So venous return, increases during inspiration, and the heart sort of expands as well. So meaning that all the initial movements are happening because, the lungs are deciding that the heart gets to fill with blood in inspiration. So that's kind of, how I imagine how this swing happens between the heart and the lungs. So that's just in, the anatomical, imagination of things. But physiologically, we have a lot of things that are happening in these processes. So, and over this presentation, we're going to see that the different, in a normally breathing patient who is, at sea level, there's lung and heart interactions lead to physiologic changes that don't necessarily cause a change in hemodynamic status. So we're going to go over these different interactions and how they, lead to the different physiologic changes in the body, but not necessarily causing a change in the hemodynamic status. We'll also look at how mechanically ventilated patients how heart and lung interactions happen in mechanically ventilated patients. And then finally, we'll look at how patients that are having clinical pathology, how clinical pathology affects how the heart and lungs function. And yeah, specifically, we'll look at the different lung pathologies and a bit of heart pathologies and how they affect how the heart and the lungs function. So just to briefly introduce things, like I mentioned, when the heart moves out, when the lungs are relaxing during inspiration and getting filled with oxygen, the chest wall moves out, the diaphragm flattens, so that it reduces the intrathoracic pressure and allows venous return into the heart. So that is really how everything, just a moment, I'd like to close off something. Yeah, so that's really how things start up within the chest and the heart. So initially there's a reduction in the intrathoracic pressure, and that happens during inspiration when the diaphragm and the chest cavity moves out. But like I mentioned, this doesn't cause a change in the hemodynamic status of the patient. So this just happens at a normal physiologic level, and the patient's pressure, heart rate are going to remain the same. The stroke volumes might change a bit, but that doesn't manifest clinically. So the patient just essentially remains normal in everything. However, when patients have pathologies like COPD, acute left heart failure, ARDS, we're going to see how these influence the heart and lung interactions. So just in a nutshell, anatomically, this is how the chest is structured. We do have the trachea that brings air into both sides of the lungs, so the lungs inflate, and we do have an interconnection of blood vessels that move from the heart and into the lungs, and specifically we have the pulmonary veins that perfuse both sides of the lung, and they take oxygen from the, blood from the right side of the heart. And that goes on to perfuse the lungs, which blood gets oxygenated and returns to the left side of the heart, meaning that changes in pressure in the pulmonary system could actually affect essentially the right side of the heart, because you're seeing that it's the one that's interconnected, that sort of perfuses blood under pressure to the lungs on either side. So if you have pressures rising on either sides of the lungs, then that could affect the pressures in the right side of the heart and could cause them to dilate. So these interconnections are what influence the lung pulmonary interactions. At a microscopic level, there's really a lot of things that are happening, but grossly, this is how we imagine how everything happens. So yeah, just to start off, in a spontaneously breathing patient, these effects of lung and heart interactions, like I mentioned, do not cause necessarily physiologic derangements in the patient's hemodynamic status. But what we tend to see is that at a measurement level, there are a bit of reductions, but they don't result into clinical manifestation of symptoms. So when initially the heart is, the lungs are filling with oxygen, like I said, there's a widening of the chest cavity and flattening of the diaphragm. So that creates a negative intrathoracic pressure that allows, air to move into the chest. So because of that negative pressure, The left side of the heart, I want you to remember that that's the weaker portion of the heart. So it's very responsive to changes within the chest cavity. So anything, that reduces pressure in the chest, the right ventricle sort of responds way faster than the left ventricle because, it's weaker, its myocardium is thin, so it tends to stretch and relax very freely compared to the left side of the heart. So when the chest widens, air returns, oxygen returns to the left side of the heart. Blood returns to the left side of the heart from the rest of the systemic blood vessels. So that causes, an increase in the right ventricular preload, and hence the stroke volume on that side of the heart. However, what happens to the right ventricle, to the afterload, is that there's a bit of an increase because, when air is getting into the alveoli, they tend to distend, and there are capillaries that run along the membranes of the alveoli. So these are pushed, kind of get occluded by the distending alveoli. So resistance in them increases. That affects how much blood passes through them. So the pressure that the right ventricle is supposed to overcome to push blood to the alveoli or lungs in this case just marginally increases because you have an increase in the resistance in the pulmonary vessels that are within the alveoli that are distending with air during inspiration. However, in the left ventricle, we tend to see things happening differently. And what we see is that when the lungs are expanding and the alveoli are getting distended, like I said, the right ventricle is filling with blood, so its preload increases. When the preload increases, the right ventricle sort of dilates a bit. And remember, the heart is contained within a rigid pericardium, which doesn't allow it to stretch so well, right? So when blood returns a lot to the right side of the heart, the pericardium doesn't allow the heart to necessarily take all this blood. So the left side of the heart sort of fills with little blood in that case because there's not so much room for all this blood to return because the right is dilating a bit and it's not allowing a lot of blood to fill into the left because there's no space to accommodate all this venous return. So these things all happen at physiologic level, and we don't see hemodynamic instability happening because of these changes. And what happens to the left ventricular afterload is that uh, it sort of increases, but also we don't see this manifest clinically because the the you have a reduction in the intrathoracic pressure during inspiration. So the extra pulmonary or extra alveolar blood vessels, the blood vessels that are outside the chest cavity, are going to be at a higher pressure compared to those that are within the chest cavity. So meaning that the left ventricle, the aorta, and the thoracic aorta in this case, are going to start off, the phase of systole at a lower pressure compared to the vessels that are outside the chest. So meaning that the heart needs to contract more strongly to overcome a higher force that's within the extrathoracic blood vessels in this case. So we see a bit of an increase in the left ventricular afterload. But like I said, none of this manifests clinically, but rather these changes are happening at physiologic level. This image looks a bit of fuzzy, but these are things that I've just been talking about. On the left, we have a spontaneously breathing patient, and these are the changes that we see, but none of them, gets to manifest clinically because they're just minute alterations in the volumes and pressures within the different chambers of the heart. So we're going to see what happens in a mechanically ventilated patient. And these are things that are, just highlighted here on the right. This is just an illustration of things, but then in the subsequent slide, I'm going to talk about it in more detail. So this EKG just represents what happens in a normal heart of a patient who is respiring at sea level. So what we tend to see is that in some healthy hearts, we tend to have a bit of irregularities in the heart rhythm. And what this actually the reason this happens is because, like we've seen during inspiration, there's an increase in the venous return to the heart. So there's an increase in the right ventricular afterload. So in that phase of the heartbeat, the heart tends to beat. In that phase of the cardiac cycle, the heart just tends to beat a bit of faster to try and expel all this increasing, blood that's returning to the right side of the heart. So what we tend to see in that case is the heart runs a bit faster during inspiration than it does in expiration. So on an EKG, you might see, an irregularity in the R to R intervals, but what that actually means is that it's a normal heart that just, beats a little bit of faster during inspiration and slows down in expiration. And this is what we describe as a cardiac arrhythmia. So when you see such a thing in a young, healthy person, you shouldn't think that they're having pathology or anything. Just simply means that during inspiration, there are these changes that are happening in how the heart and lungs are interacting, and they could cause a change in how the cardiac rhythm might appear in an EKG. So in mechanically ventilated patients, things tend to change up because, as you probably know already, in mechanical ventilation, there's positive pressure insufflation into the lungs during expiration. So the difference with, a spontaneously breathing patient is that in spontaneous breathing, everything is happening at negative pressure. I mean, during inspiration, it's just a negative pressure that's created in the chest. But during mechanical ventilation, there's positive insufflation. I mean, there's insufflation of air at a positive pressure. So things are a bit of, reversed from what happens in a physiologically breathing patient. So on the right side of the heart, again, I said this is the weaker portion of the heart. It's more responsive to changes in pressure than the left side of the heart does. So during positive insufflation of air in mechanical ventilation, we tend to certainly see a rise in the intrathoracic pressure. And this is going to affect how much blood returns to the right side of the heart. So because of an increase in pressure in the chest beyond the systemic blood vessels, so there's going to be a bit of struggling in how blood returns to the right side of the heart. So the preload to the right side of the heart is going to go down just a bit in mechanically ventilated patients. But also in this doesn't, cause any hemodynamic issues if you're ventilating patients at a normal tidal volume and a normal PEEP, and also if patients are normally anormotensive or having a normal, circulating fluid volume. So these changes happen, but they're usually very minute to cause hemodynamic instability in patients who don't have those three things. One is they're not hypovolemic, so the volume is good, and you're ventilating them at normal tidal volumes and normal PEEPs. So the pressure that increases doesn't manifest clinically, but it's just happening. And we know that physiologically there is a bit of reduction in preload to the right side of the heart. The factors that actually cause this counterbalance for the reduction in preload not to be very significant to cause hemodynamic instability in patients who are under mechanical ventilation. And one of them is that when you're pushing the diaphragm down during insufflation, that increases intra-abdominal pressure and allows a bit of venous return to the heart. So it kind of counteracts the increase in intrathoracic pressure that reduces preload to the right side of the heart. And also because during insufflation, there's sort of a sympathetic overstimulation, which causes vascular constriction and also facilitates venous return to the right side of the heart. So on the right still, there's going to be a reduction in the afterload. So the reason this happens is that, there's going to be an increase in the afterload. So the reason this happens is you're insufflating positive pressure air into the lungs. So there's going to be an increase, definitely. A distension of the alveoli. And when alveoli are distending, they're going to push onto the pulmonary vessels and increase resistance that the left side of the heart is supposed to overcome to pump blood into the rest of the lungs. The right side of the heart is supposed to overcome to pump blood into the rest of the lungs. However, this also doesn't really cause any clinical issues unless the patient has, say, a pathology on the right side of the heart, or you're ventilating them at a very high tidal volumes. Because if they're low tidal volumes, then the lungs, if they don't have any pathology, say they're not fibrosed, or the patient doesn't have anything that impairs lung compliance, like ARDS. So the lungs should normally expand and accommodate all this tidal volume that you're putting into them, and thus they will not compress the pulmonary blood vessels more to cause a significant reduction in the afterload. So that means that patients that are having less lung compliances, say they're having ARDS, they're having lung fibrosis, their tidal volume should be maintained low because when you put in a lot of tidal volume and the lungs are not expanding, then that's going to impair it's going to significantly increase the afterload for the right side of the heart and could cause them to get an acute right heart failure because there's a lot of force that the right ventricle is supposed to overcome to pump blood into the lungs. So for the left side of the heart, again, these are very easy things to imagine. So when you have positive pressure being insufflated into the lungs, there's certainly going to be an increase in the transpulmonary pressures. And when pressures increase in the pulmonary blood vessels, they will sort of just squeeze the blood vessels and allow more blood to return to the left side of the heart. So that would cause an increase in, the left ventricular preload because you're facilitating blood to return to the left side of the heart by squeezing blood vessels within the pulmonary vasculature. So for the left ventricular afterload, this is one way the pendulum actually supports each other. So what happens in patients that are under mechanical ventilation, the positive pressure that you're insufflating into the alveoli is transferred or transmitted to the left side of it's transmitted to the left ventricle and just sort of facilitates how that contracts. So that causes a reduction in afterload because you're sort of facilitating the contractile strength of the left side of the heart. So this is the last component of my presentation, and here I'm just going to, just briefly take us through how the different pathologies might affect how the heart and lung interactions happen. Again, I'll talk about the very key and commonest lung pathology, that affects how the heart and lung interacts, and that's in patients who are having acute exacerbation of COPD. So in these patients, we know that they're air trapping, so there's an automatic PEEP that's in them. So even before they start to inflate, inspire air during inspiration, there's already air that's trapped inside into their alveoli. So that's what a phenomena that's described as intrinsic PEEP. So they're already having air at the start of inspiration. So when that happens, it means that their lungs are already sort of hyperinflated even before the start of inspiration, and their diaphragms are already down and flattened, and the chest is already sort of moved out before they start inspiration. So when they start to inspire, the chest again is going to move out. It's already expanded and the diaphragm is flat, but when they're inspiring, that becomes, it increases. So that causes a significant reduction in the intrathoracic pressure compared to a normal patient who doesn't have COPD. And that causes, because the diaphragm is already down and flat, it just further moves down into the abdomen. And that causes an exaggerated increase in the intra-abdominal pressure, which pressure is transmitted to the IVC, and that could cause a drop in the right ventricular preload because the IVC sort of gets compressed when the pressure increases a lot in the abdomen. And this happens in patients who are having acute COPD exacerbation, meaning that they're having very severe labored breathing and they're having a very high inspiratory effort. So they're taking in a lot, they're trying to take in a lot of air to compensate for the hypoxia that they're in. And that, increases intra-abdominal pressure and drops the right ventricular preload because it compresses onto the IVC. So for the afterload, we know that patients that are COPD are hypoxic almost always. So they have a degree of hypoxic vasoconstriction, and that causes a rise in the pulmonary pressures. So they have a degree of pulmonary hypertension because of the hypoxic vasoconstriction. So because of those pressures, the left side of the heart has to pump against the higher resistance, which increases the afterload for that side of the heart. So studies have actually found that in patients that are having acute exacerbation of COPD, they experience an acute failure of the right side of the heart, and that happens in about 20 to 30% of patients. But because echoes are not routinely done, so some of these go unrecognized. But it's important to know that all patients that come in with COPD, they'll get a degree of right heart strain and failure because of increase in the right ventricular afterload because of hypoxic vasoconstriction. So this is how an echo would look like in a patient who is having acute right heart strain and failure due to, say, COPD. So the echo will essentially demonstrate a widened right side of the heart because it's going against high pressures within the lungs. So these pressures back up into the heart and cause dilatation of the right ventricle and the right atrium, as you can see on the right. So typically the left should be bigger than the right, but in this case the right is really dilated and it's almost twice the left of the, almost twice the size of the left side of the heart. So this is, very classic of a patient who is having acute right heart strain and failure because of, increase in pulmonary pressures that could be due to COPD. And then on EKG, still same thing. When you have a dilated right heart, it's going to pull a lot of energy towards itself. So we tend to see an axis deviation. So, a lot of energy is moving to the right side of the heart because it's dilated. So on ECG, when you look at lead V1 and AVF, you see that we have more energy moving towards the right side of the heart. So you get a right axis deviation where the AVF lead stays positive while lead one gets negative or inverted, as we can see in this EKG. So the other typical feature to look at on EKG of a patient who is having right heart strain is you'll see, lead V1 typically sits over the right side of the heart. So it sits over the right ventricle in its natural anatomical, position where we place it. So when you want to look at pathology in the right side of the heart, you're essentially going to concentrate on lead V1. And what we see in lead V1 is that it also tends to take up a lot of energy compared to other leads because the right side of the heart is dilated. And what we see in this case, we have what we call a dominant arrow wave in lead V1. So if to remember how a normal EKG looks like, it will have typically a P wave in V1. Then you don't essentially see Q waves in V1, but then you'll have a very small R wave and an S wave. But then when they have a right ventricular dilatation, then we tend to see V1, the R wave in V1 becoming large, as we can see. So it's pulling a lot of energy towards V1. And essentially it happens in V2 because it's the same lead also, it sits over the right ventricle. So changes that happen in V1 can also happen in V2. Then the other key feature is that you see, you see ST segment depressions, and these happen because you're having abnormal contraction, and hence the repolarization is also abnormal. So we tend to see S-wave inversions in patients who are having a dilatation on either side of the heart. So there's a lot of clinical things to note in patients who are having, COPD, hypoxic vasoconstriction. But again, I included this slide to essentially, remind us that patients who are COPD tend to get pulmonary hypertension. And then it's really typical practice for most people to give them pulmonary vasodilators, so things like bonsetan, phosphodiesterase inhibitors like sildenafil. But the actual physiology actually tells us that these patients may not respond to most of these drugs. So the typical way to treat them should be, to correct the hypoxia and try and treat the underlying cause, because from how these drugs function, they would actually just in very different ways. So bonsetan, what it does is that it increases endothelin. It blocks endothelin 1 receptors. So meaning that in patients who are having remodeling due to hypoxic vasoconstriction, that drug may not necessarily have a role in trying to reduce the pulmonary hypertension. So there are 4 types of pulmonary hypertension. The first type is really idiopathic. They don't really know what happens, but why the mutation happens, but it causes an increase in endothelin synthesis and a reduction in nitric oxide. So these are the typical patients who would respond to drugs like bonsetan and other pulmonary vasodilators. Other patients with other types of pulmonary hypertension may not typically respond to these drugs. So probably most people use them outside evidence, but they're not really the game changer in patients who are having hypoxic vasoconstriction. So acute right heart failure, these are patients who are, who present typically because the left side of the heart is failing to pump blood out of itself. So they're having a reduced ejection fraction. And what this actually happens is that blood is going to, stagnate into the left side of the heart, and it will back into the lungs, causing pulmonary edema. So these patients will have a reduction in the left ventricular preload because the lungs are not compliant enough to expand and accommodate all the air that's coming in during inspiration. And also because of the edema, they'll have a reduction in they'll have hypoxic vasoconstriction because of reduction in because of the ventilation perfusion mismatch that's caused by the pulmonary edema. So they'll have an increase in the right ventricular pressures and a reduction in the filling of the left side of the heart because the pericardium is really stiff and doesn't allow more blood to return to doesn't allow blood to fill into the left side of the heart because the right is as well dilating because of increasing pressures in the lungs. So when they're mechanically ventilated, these are the typical patients who will actually get better when you put them on mechanical ventilation. Like I said, when a patient is having RV failure and you put them on mechanical ventilation, the force of insufflation is transmitted onto the left ventricle and the intrathoracic aorta. So that just sort of improves how it contracts. So patients with right heart failure will essentially benefit from mechanical ventilation of any sort, whether you're using, invasive or non-invasive ventilation, they should ideally get better. Some patients tend to experience pulmonary edema when they're being weaned off mechanical ventilation. And again, this is easy to, imagine how it happens. When you're taking a patient off ventilation, means that they're going to switch from positive pressure inspiration to negative pressure inspiration. So what happens is initially you're using a pressure to insufflate air into them during inspiration. But when you take off the vent, they're going to start to breathe on their own. So the negative pressure that happens during inspiration is going to cause a reduction in the right ventricular preload. An increase in the right ventricular preload, which was actually opposite with what happens during mechanical ventilation. So because of the negative pressure created during spontaneous breathing, there's going to be an increase in the right ventricular preload and hence the afterload also, because you know that when they're filling the alveoli with air, they distend and sort of increase resistance within the pulmonary veins. So because of an increase in the right ventricular filling, I said the pericardium is stiff, so the left ventricle is also going to feel less. So there's going to be an increase in the left ventricular filling because of an increase in the right ventricular preload. So that will cause blood to back up into the lungs a bit, and it will cause an increase in and it will cause a bit of pulmonary edema because less blood is returning to the right side of the heart. So the reason this happens is because when you're weaning them off mechanical ventilation, you don't allow them enough time to physiologically adapt to the negative pressure ventilation, which they're switching to from the positive pressure which they were under during mechanical ventilation. But this doesn't happen in all patients. Studies have found that patients that have COPD, cardiomyopathies, and obesity are the ones that tend to experience it more compared to, patients who don't have these risk factors. All right, so this is probably one of my last slides. Patients that are having acute respiratory distress syndrome. So what happens in these patients is that the alveolar membranes are sort of destroyed and replaced with a pseudomembrane, which is kind of fibrotic and doesn't allow the lungs to expand normally. And then also because of this, you're going to have perfusion ventilation perfusion mismatches. So they will be hypoxic and they'll have hypoxic vasoconstriction. So when you're ventilating these patients, it's recommended that you use low tidal volumes and also titrate their PEEPs to, their FiO2. So the reason for this is because the lungs of patients that are having acute respiratory distress syndrome are less compliant. So when you give them high or normal tidal volumes, they're going to cause marked increase in, intrathoracic pressures, and that will affect how the right side of the heart functions. So for that reason, it's recommended that we use low tidal volume ventilation strategies, and also PEEP should be titrated according to how much FiO2 they are getting. So their ventilation shouldn't typically happen the same way you do it for patients without ARDS. So also patients with ARDS tend to experience acute heart failure, and that happens in about 20 to 25%. The reason this happens is, again, hypoxic vasoconstriction. So they're having an increase in the right ventricular afterload because of the high pressures in the lungs that the right side has to overcome to push blood there. So the right side of the heart tends to start, to fail because the pressures that it's supposed to overcome. So lastly, I'll talk about how we use the heart and lung interactions to predict fluid responsiveness in patients that are critically ill. And there are very many dynamic parameters that are proposed and can be used in these patients. And one of them is the pulse pressure variation. So there are also static parameters, but studies have found that static parameters are not, that accurate in predicting fluid responsiveness. And for patients that are critically ill, it's recommended that you use, those tests that are going to give you an accurate look at how their fluid responsiveness is going to be. So one of the tests is the pulse pressure variation. And what this actually means is that we're looking at how the pressure within the blood vessels, or how this, in actual sense, what it means is that how much volume is circulating within the blood vessels. Because we know that at a constant resistance within the blood vessels, the only determinant of blood pressure is actually stroke volume. So when you measure pulse pressure, when you measure how pressure within the arterioles vary in patients that are having a normal vascular compliance, then that could give you, an accurate way of determining how much volume is circulating within those blood vessels. And the one test that we use is this. So here you typically do it in patients that are having an A line. So and it's going to show you how pressure varies over a certain period of time. And what you're going to look out for is, one, how you're going to look for the largest wave in over a certain time, and then the smallest wave. So you calculate the difference in the diastolic pressure and the systolic pressure in the largest wave. So it's going to give you the maximum pressure variation. So what we see with the red arrows here is that this is probably the biggest wave amongst all these waves. And when you calculate the difference in the systolic and diastolic pressure at this point, it will give you the maximum pulse pressure variation. And the smallest is this, which gives you the maximum pressure
Hey,
variation. So when you compute these into this formula, they should give you pulse pressure variation.
apologies.
And a normal pulse pressure variation should be between 10 to 15. So any figure beyond that, since stroke volume is varying a lot, and it could mean that because they're having, a low stroke volume, and that reason could be because they are hypovolemic. So patients who are having a wide pulse pressure variation typically respond to IV fluids. A bit of limitations to this test is that it has to be done in patients who are spontaneously breathing. It should be done in patients who are under mechanical ventilation. It's very ineffective in those who are spontaneously breathing, because we saw that the physiologic changes in patients that are spontaneously breathing are typically different from those that are under mechanical ventilation. And then if you have a high PEEP or a high tidal volume that you're using to ventilate these patients, then the test is also going to be falsely positive, because we know that a high PEEP and high tidal volume reduces how much blood returns to the right side of the heart. So it's going to cause a reduction in the stroke volume. So there will be very large variations in pulse pressure, and you would falsely assume that that variation is because of, reduction in stroke volume. That's due to hypovolemia, but in actual sense, it's due to the high PEEP and high tidal volume. All right, so other dynamic parameters that are suggested are things like IVC collapsibility index, where you use the ultrasound to measure the diameter of the IVC during inspiration and expiration, and you see how that varies, over time. And a high IVC collapsibility index indicates that the patient might be fluid depleted and might, be responsive to IV fluids. Then the other measure is doing a passive leg raise. We know that when you raise the patient legs, you sort of auto-transfuse about 500 mils of blood back into the heart. So when you do that and the pulse pressure variation reduces, it means that this patient needs fluid. So you auto-transfuse them with fluid that was in their in their legs, and it caused an increase in the stroke volume. So pulse pressure variation went down. So patients that have a positive leg raise test would typically be fluid responsive. Then the other things to do is that you can do a direct measurement of the stroke volume after doing a passive leg raise, and an increase in stroke volume would mean essentially that this patient is going to be fluid responsive. All right, so that's my last slide. I just want to conclude by giving some few takeaway points. So heart and lung interactions essentially happen in spontaneously breathing patients and those that are under mechanical ventilation. And also the key changes that happen in patients who are having, pathology to the lungs or the heart. So it's important that anyone that, works in the critical care settings understand how these interactions actually vary and how they might influence, the kind of interventions that we deliver to these patients. So means that, patients that could say have right ventricular heart failure, these patients, we say that they're very preload dependent. Intubating these patients and putting them on mechanical ventilation would actually be more deleterious than looking for other ways of improving their hypoxia, because seeing that mechanical ventilation reduces preload to the right side of the heart. So if the right is already failing and you're putting them on mechanical ventilation, that could, make the function of the right side of the heart even more weaker. So meaning patients that are having right heart failure should be intubated only if it's the last option that can get their oxygens up. The other patient category to consider, the ones that are having acute left heart failure. Like I said, those patients tend to improve when you put them on mechanical ventilation, because the positive pressures sort of facilitate contraction of the left ventricle. So these patients should typically improve when you put them on positive pressure ventilation. Another key thing to note is that we need to always understand how heart and lung interactions can be used to predict fluid responsiveness in critically ill patients. All right, so that was my slide. I would like to thank you all for listening for all this long. I don't know if we're taking questions at this point or any comments, but I think Dr. Erasmus will guide on that. So I'll let Dr. Erasmus take over the discussion at this point.
Nice. Thank you, Dr. Kamoga. Thank you very much for this rich talk. We spent quite a bit of time on it because it founds the rest of the discussions. The connection of the other organs to the lung really also has a component of the cardiovascular. So this is quite a lovely introduction to everything. So let's have questions over the next 7 minutes. So the first question on the chat is from Dr. Rachel. She says, I would expect the changes that happen on the RV during mechanical ventilation to occur also on the LV. What causes the difference? Then the second question is from Dr. Preach. He says, thank you for the presentation. In a patient with the respiratory failure requiring mechanical ventilation, but also has ASD stroke PF4, how will you optimize the PEEP during mechanical ventilation to ensure adequate oxygenation while preventing increased right to left shunting? Over to you, Dr. Kamoga. And you can always ping your mentor for this.
Dr. Rasmus, I'm really sorry. I think I missed Rachel's question, but it's probably what I'll respond to successfully. So
That's everything. You respond to all questions. But
if you could,
Rachel's question, he expects the changes on the RV also occur on LV during mechanical ventilation. Why is there a difference between?
Erasmus, you're breaking. I'll probably read it in the comments myself. But yeah, for Dr. Rich's question, I would really like to flag it to the mentor in this case because it's kind of complex for me. So what's PFO? It's probably something that I'm not very familiar with.
It's patent foramen ovale. This is a
Oh,
shunt.
okay. So okay, so I'll respond to Rachel's question first. She asks, I would expect changes that happen on the RV during mechanical ventilation to occur also on the LV. What causes that difference? Oh, so like I explained, during mechanical ventilation, you do have positive insufficient of air at a positive pressure. And so what happens is that the alveoli are getting distended with positive pressure. So that's going to affect how much blood returns to the right side of the heart. So there's going to be a reduction in the right ventricular preload in that case. However, on the left side of the heart, when alveoli are getting distended, they sort of push blood outside the alveolar components. So that facilitates more blood to return to the left side of the heart. So that that increases the left ventricular preload in that case. However, the force of, insufflation is transmitted to the left ventricle as well, and the intra-aortic component of the aorta. And the intrathoracic component of the aorta. So that force just sort of facilitates how well the left side of the heart contracts and increases, and that reduces the left ventricular afterload. Because one thing I'd like you to remember is that afterload is the force that a particular chamber of the heart is supposed to overcome to push blood out of itself. So when you're increasing the contractile power of that side of the heart, it's going to reduce the afterload because the pressure is going to be higher compared to the extra thoracic components of the blood vessels. So afterload is going to go down. So the next question from Dr. Preach is that in a patient who is having respiratory failure, requiring mechanical ventilation, but also having an ASD and a patent foramen ovale, how will you optimize PEEP during mechanical ventilation? So I'll attempt to respond to this. So we know that an ASD and a patent foramen ovale are essentially going to cause a shunt from the left to the right because pressures on the left are typically higher than on the right. So when these patients are put on mechanical ventilation, there's going to be an increase in the intrathoracic pressure during insufflation. So meaning that the PEEP that you're going to give these patients has to be higher to try and block the left to right shunt. So when you give them a higher PEEP, it means that you're sort of you're increasing the force with which blood is supposed to move from the left side. You're sort of disfavoring moving of blood from the left to the right side of the heart because you're increasing pressure in the lungs in this case. So I feel like a higher PEEP would sort of optimize this patient's oxygenation. If I've tackled it wrongly, then I would think that Dr. Erasmus and Dr. Cornelius can actually give an input on this.
All right, so we shall have the mentor chime in as soon as he joins. I'm going to save the question so that he stays within the family. in this case. I guess I have one question though, as we sign off from this topic, and that is, could you explain the role of pulsus paradoxus in the management of respiratory disease, obstructive respiratory disease, and also explain the use of airway occlusion in hemodynamic monitoring?
Oh, wow. So again, I'll attempt. So for the first question, what I know about pulsus paradoxus is that it's an exaggerated drop in the blood pressure during inspiration or during air insufflation into the lungs. And the reason this happens is that when, during insufflation, when lungs are getting distended with air, there's going to be, yes, a reduction in the preload to the right side of the heart, and hence an increase in, a reduction in the right ventricular preload. So that is going to translate into how much stroke volume is pumped out of the left side of the heart. So when there's a reduction in what returns to the to the right side of the heart, less is also going to the left during expiration. So there's going to be a general reduction in stroke volume during inspiration, and that will cause an exaggerated drop in blood pressure because of a reduction in stroke volume. And so how we use this in the clinical world is that patients who are, say, having increase in any conditions that increase the intrathoracic pressure or reduce lung compliance, these patients will essentially get a more exaggerated drop in the blood pressure because you're reducing preload, and then the right side of the heart is also having issues pumping blood into the lungs because there are a lot of pressures there, either from reduced lung compliance or from hypoxia that's causing, hypoxic vasoconstriction. So the reduction in preload is again further worsened by an increase in the afterload. So there's generally going to be less blood returning to the left side of the heart and less that's getting out into the lungs. Hence, a more significant reduction in what returns to the left side of the heart and a reduction in the afterload. So when we're treating these patients, say with mechanical ventilation, these patients would essentially need a very low tidal volume ventilation. They'll need a low PEEP because you don't want more pressures into their lungs, affecting further the already reduced venous return. So for the next question, Dr. Asmus, I would probably refer it to any person on the chat who can respond to it.
No problem, Doctor. Thank you very much for serving us in a way today. So I would like to bring this to a conclusion. We shall revisit some of these questions later, especially when the mentor joins us. So for now, I would like to have you retire your slides and we introduce the next speaker. All right, so we are crossing from the lung and heart all the way to the lung and the liver. So in this case, we are going to have Dr. Halima take us through the interaction between the liver and the lung. So this is the hepatopulmonary axis. Dr. Halima is a third-year resident in analytics and critical care at Makerere University. So over to you, Doctor. Please proceed and share your slides. You've got about 25 minutes so that we save more time for discussions.
Good evening once again. I'm Halima Kaitesi. And today I'll take us through a very important topic, which is the hepatopulmonary axis. This is a very critical area looking at the liver and the lungs, and very important pathophysiology and clinical implications. I once again acknowledge my mentor, Dr. Erasmus. So these will be my objectives. We shall look at, shall have an understanding of the bidirectional impact between liver disease and lung function, look at the pathophysiology of hepatopulmonary syndrome, different mechanisms of portopulmonary hypertension, etiology, presentation and management of hepatic hydrothorax, and then explore the different treatment strategies for hepatopulmonary conditions. So how does pulmonary dysfunction affect or impact liver health? So we have one of the most common condition, which is congestive hepatopathy from pulmonary hypertension. I will not delve much into this. However, anything that causes pulmonary hypertension, things like COPD, in a long run leads to increased RV systolic pressure, RV hypertrophy, backflow of blood, and finally we have congestive hepatopathy. Impact of liver disease on lung function. The most common conditions we see are hepatopulmonary syndrome, portopulmonary hypertension, and hepatic hydrothorax. And I'll talk much about these in detail. Looking at hepatopulmonary syndrome, this is a triad of abnormal arterial oxygenation caused by intrapulmonary vascular dilatation in a setting of liver disease or portal hypertension. So this is most commonly seen in patients with chronic liver disease, particularly those with portal hypertension. So how it happens is in a patient with liver cirrhosis and chronic liver disease, so we have impaired clearance of toxins and gut-derived bacteria, which leads to bacterial translocation and endotoxemia. So this further activates, leads to activation of monocytes and macrophages that release inflammatory mediators like TNF-alpha, which then migrate to the lungs. So in the lungs as well, we have endothelin-1, which is a potent vasoactive peptide, and it's upregulated, binds to its receptors and stimulates endothelial nitric oxide synthase, which leads to production of nitric oxide, and this causes vasodilatation. Simultaneously, the activated monocytes and macrophages activate inducible nitric oxide, further producing nitric oxide and exacerbating vasodilatation. So liver dysfunction as well increases vesicular endothelial growth factor A, which promotes angiogenesis and endothelial proliferation. And in a long run, this also leads to abnormally dilated formation of abnormally dilated capillaries in the pulmonary circulation. So we have excessive vasodilatation and angiogenesis, leading to shunt creation, and this ultimately leads to hypoxemia. So this image further explains mechanism of hypoxemia. So on the left side of every diagram here, we have blood from the pulmonary artery carrying deoxygenated blood to the alveoli. So we see oxygen diffusing efficiently across the thin alveolar capillary membrane into the small capillaries. So here blood is fully oxygenated before actually entering the pulmonary vein. So we have effective oxygen exchange, we have no significant shunting, and we have our arterial oxygenation is normal. And then on the right side of every diagram here, we have a patient with hepatopulmonary syndrome. So due to the excessive nitric oxide and angiogenesis that we saw earlier, we have abnormally dilated vessels, so which creates two problems. So one, we have diffusion limitation. So we see that oxygen must travel a greater distance to reach the center of the dilated vessel, leading to incomplete blood oxygenation. Two, we have intrapulmonary shunting on the right side of the diagram. We see some deoxygenated blood bypassing the alveoli, leading to worsening hypoxia. So the resulting, the overall result in hepatopulmonary syndrome is arterial hypoxemia. So this explains the same thing. So how do these patients present? Like I said earlier, this syndrome occurs in a setting of chronic liver disease. So patients exhibit signs and symptoms of chronic liver disease. They'll have fatigue, ascites, among other signs and symptoms. In addition to these, we have signs and symptoms, respiratory symptoms, including dyspnea due to the vacuum mismatch. We have platypnea. This is positional dependent dyspnea due to the shunting of blood, as well as orthodixia. Then finally, we have hypoxemia. So diagnosis, the diagnosis is based on clinical suspicion and shunt assessment. So yeah, so images may not be helpful in this syndrome diagnostically, but can rule out other etiologies. So we can determine the level of hypoxemia by doing serial ABGs, and then we can do a shunt assessment by doing some of the images like transthoracic contrast echo, transesophageal and intracardiac echo, and maybe a contrast pulmonary angio. Treatment depends on severity. For patients with mild to moderate hepatopulmonary syndrome, we can do more of observation, and then we can also relieve symptoms by giving them oxygen, though this is still periodic due to the excessive dilatation we saw earlier. For severe cases, still we do symptomatic relief. The definitive treatment is liver transplant. Refractory, the options are actually really limited, though we can still relieve the symptoms by doing maybe a transjugular intrahepatic portal systemic shunt, relieve the portal hypertension, and also embolization, maybe to block the abnormal blood vessels. And we can also use vasoactive medication. Going on to the next syndrome, which is
Dr. Kaites, you're still there?
Although we have numerous theories that have been proposed, the most common one is the imbalance of vasoconstrictive and vasodilatory mediators like serotonin. So what happens is normally these substances are produced and they are metabolized by the liver. However, in portal hypertension, portopulmonary hypertension, these substances bypass the liver and reach the pulmonary circulation through the collaterals, postsystemic collaterals. So these substances are potent vasoconstrictors, and they cause excessive vasoconstriction, leading to portopulmonary hypertension. So, for example, serotonin and interleukin-1 promote proliferation of smooth muscle cells, causing thickening of the arterial walls, making them stiffer and less flexible. Things like thromboxane B2 increases tendency of platelets to stick together, leading to microclots in the lungs, leading to resistance to blood flow, and so on. So some genetic mutations related to cell growth are said to also contribute to this condition. And as well, thromboembolism further also is said to contribute to portopulmonary hypertension. This condition is a hyperdynamic condition. How in chronic liver disease, remember we have scarring, fibrosis, many nodules that actually can block normal blood flow. So this always leads to portohypertension. So the body tries to compensate to this by dilating blood vessels in the splanchnic circulation, like the intestine, spleen, and so on. So you have increased vasodilatation in the body. As a result, you have more blood flowing into the pulmonary arteries, into the lungs, stress on the walls of the blood vessels. So over time, these vessels remodel, thicken, and stiffen, and finally, in the long run, you get portopulmonary hypertension. So the diagnosis of this condition is based on the history of portal hypertension. We do a right heart catheterization to look at the pressures. For example, the mean pulmonary artery pressure of more than 25 at rest and more than 30 with exertion, and also the pulmonary vascular resistance that is increased. However, when you look at the LV and diastolic pressure, it's always normal, and we also exclude other pulmonary hypertension etiologies. So treatment, we can do general measures and direct therapy. So we can, for pulmonary artery hypertension related, we can do prevention. We can avoid factors, any factor that worsen pulmonary hypertension, things like hypoxia, infection, volume overload, etc. We can also do supportive measures, give oxygen to reduce pulmonary vasoconstriction. We can manage the right heart failure of volume overload with diuretics. For portal hypertension related measures, we can it's always advisable to avoid beta blockers and performance of TIPS. This is said to worsen right ventricular dysfunction and also right heart failure strain. So the definitive treatment this condition is liver transplant. So the directed therapy treatment depends on WHO functional status. For class 1, we do more of observation. Class 3 to 4, we can do pharmacotherapy. For example, we can give endothelin receptor antagonists like bosentan, which relaxes the pulmonary arteries. We can give prostacyclin agonists, which promotes vasodilatation. We can do combination therapy, and also you can consider nitric oxide enhancers. So, and finally, I'll discuss what hepatic hydrothorax is and its pathophysiology. So this is defined as the pleural effusion, typically more than 500 mL in patients with liver cirrhosis without coexisting underlying cardiac or pulmonary disease. So in most cases, about 80% Hepatic hydrothorax develops on the right side, with 13% on the left and 8% bilaterally. So this predominance on the right is due to anatomic differences in the diaphragm and the liver's position. The right side of the diaphragm is thinner, more tendinous with congenital fenestrations, while the left side is thicker and more muscular. So these defects allow acidic fluid to pass more easily from the peritoneal cavity into the right pleural space. So the pathophysiology, the exact mechanisms involved are actually still not been well defined. However, we have several postulated mechanisms like hypoalbuminemia, increased venous hypertension, azygous vein hypertension, transdiaphragmatic migration of peritoneal fluid into the pleural space via the lymphatic channels. However, the most widely accepted theory is the direct passage of acidic fluid from peritoneal to pleural cavity via diaphragmatic defects. So what happens is that in these patients, in patients with ascites, so we have increased abdominal pressure and diaphragmatic thinning, probably secondary to malnutrition of these cirrhotic patients. So these enlarge the already existing defects. So, and then we have blebs forming and herniating through the defects. And if a bleb bursts, a communication between the peritoneal and the pleural space is formed. So the movement of fluid now from the abdomen to the pleural space is, starts happening, and this is a unidirectional movement, which is probably due to permanent gradient pressure as a result of negative intrathoracic pressure. So if the volume of fluid in the pleural cavity exceeds the absorptive capacity of the pleural membranes, and then we have development of this condition known as the hepatic hydrothorax. So presentation, so the prominent clinical manifestations are non-specific and related to cirrhosis and ascites in most cases. Rarely will you see hepatic hydrothorax on your index presentation for chronic liver disease. The respiratory symptoms in patients with this condition vary, mainly depending on the volume of effusion. Patients may be asymptomatic, and pleural effusion may be an incident findings really on chest imaging performed actually for other reasons. However, patients may come with dyspnea, cough, nausea, pleuritic chest pain, and acute tension hydrothorax. So diagnosis, so first of all, we should have hepatic cirrhosis with portal hypertension and an exclusion of cardiopulmonary disease. Then we can do a pleural, we can confirm with chest imaging with a pleural effusion of more than 500 mils, usually on the right side, as I said earlier. And then we can do a thoracocentesis and fluid analysis to identify the nature of the fluid and also to exclude any presence of infection. So the composition of hepatic hydrothorax, the fluid is transdative in nature, and however, total protein and albumin may be slightly higher in hepatic hydrothorax. So this is an imaging showing hepatic hydrothorax, but like I said earlier, it's really confusing to differentiate it from other causes. So what happens is sometimes when it's so confusing, they do they give a contrast in the peritoneal cavity, and you visually see it moving into the pleural space, as you see on the right side of this slide. So management is really multidisciplinary because of the overwhelming mechanism of this, this condition. The principal treatment should focus on eliminating and preventing the recurrence of ascites. If a patient is a suitable candidate, liver transplant is the definitive treatment, especially for refractory hydrothorax. We can do sodium restriction and diuretics to improve the symptoms. Therapeutic thoracocentesis can be considered, especially in patients who are severely symptomatic. Chest tubes shouldn't be placed for treatment. They've been associated with increased risk of mortality and also noted to result in massive protein and electrolyte depletion. For refractory hydrothorax, sometimes some patients, despite the diuretics and the sodium restriction, many of them still experience these symptoms, respiratory symptoms. So the definitive therapy in these patients is actually liver transplant. However, we can do symptomatic management. We can still do thoracocentesis. We can do TIPS, fluorosis, or we repair the thorax. So thank you so much. This brings me to the end of this presentation.
Excellent. Thank you very much for your talk, Dr. Halima. So right away, we go to the chat. There's one question, actually two in one. Dr. Preach is, again, thanking you for the presentation. And the question is that in a patient with fulminant liver failure causing significant SARS, capillary leak syndrome plus hypoxemia, what's the role of plasmapheresis, aka plasma exchange? And two, an hepatic status where you remove the liver without putting it back. And he goes on to comment that the two treatment modalities that are last-ditch efforts in absence of liver transplantation services that could save life. Do you have any ideas from your research?
Thank you so much, Doctor, for that question. I'd like to pin it to you, Dr. Erasmus.
Okay, thank you. I guess, Dr. Preacher, I'll ask you to chime in eventually on your experience with it. But basically, liver failure just means that your body is making so many metabolites, some of which are vasoactive in terms of causing inflammation, leak, and the like. Some of which are causing vasodilatation, some of which are causing pulmonary hypertension, as we have understood so far. And in the liver failure patient, the three mechanisms tend to coexist. There is inflammation from the floating microbes and their endotoxins from the gut, which are not being filtered and detoxified by the liver, and also shunting all over the place. There are also the peptides that are vasodilatory that are going through and broken down by the liver, and similarly the vasoconstrictive ones that are going through the lung and too much blood flow to the lungs causing the pulmonary hypertension. So it's a mixture of things. Whichever phenotype manifests eventually in the lung depends on the balance between the different mechanisms. Now, most of these are really doing it to go into the lung because the liver, which is supposed to break them down, is no longer working. So the last-ditch efforts to try to stave off the problem must work in concert with a definitive intervention that restores liver function. For example, you need something that's going to break down these metabolites. So you will probably be chasing for liver transplant. And in the process of waiting for liver transplant, you probably want to perform the specific procedures that could clear out these peptides. So plasmapheresis particularly adsorptive plasmapheresis, is a type where they put in a filter impregnated with an adsorbing chemical, maybe charcoal, or in terms of other toxins, they put in polymyxin B, and they are made with different components. And then hemoperfusion, in other words, blood is run through it. Usually, it's a combination circuit between regular renal dialysis together with the adsorptive filter put in series, so that blood is dialyzed by the renal filter and it's passed on to the adsorptive filter to remove the liver metabolites and then eventually return to the patient. So this system is named MARS, I don't remember the acronym in full, but it's MARS, M-A-R-S. In a moment, I'll remember. So basically, that is the form of plasmapheresis that is deployed in liver failure. It tends to absorb most of its metabolites because, remember, whatever goes through the liver is not water soluble. And so whatever goes through the kidney is water soluble. So that's why they usually combine that system with the regular renal dialysis together with the adsorptive one. So that is a temporizing measure that if you can clear some of these vasoactive peptides, you might buy the body time for either the liver to heal or you get transplantation. Unfortunately, by the time you reach a point of having hepatopulmonary interactions of that level and hepatovascular interactions that Dr. Rich has described in the question, it usually means that the liver is gone and you need to urgently replace it. And so the role of this is honestly zero if you will not be able to replace that liver in time. So over to you, Dr. Preach, in case there's any additional information on the subject.
Yes, thank you very much. And yeah, apologies for the question that seems to be weird. You're very right, Dr. Erasmus. They're basically last-ditch efforts. So there is that MARS, basically it's like extracorporeal liver function. So think about it, there is dialysis, there's extracorporeal membrane oxygenation, but then there's also extracorporeal liver replacement, and that's where you can use it. However, if you think about significant liver failure, so the liver has the highest number of macrophages in the body, okay? Now, if there is failure, they'll break down the dying liver and it will literally activate the inflammatory system. Now, as a result of the activation of the immune response, it will literally clear the whole body, and therefore plasmapheresis or plasma exchange, the role is basically to clear all these immune mediators and some peptides if possible, but literally you just want to clear the immune modulators that have been formed to try help reduce the capillary leak syndrome and vasoplagia. There's actually evidence, and I'm going to share it in the chat. There are some papers that have shown that indeed plasma exchange, the normal plasma exchange with albumin, with FFP in severe liver failure actually reduces mortality in terms of basically clearing the toxins, especially the immune mediators, and therefore you'll have a reduction in vasoplagia and capillary leak syndrome. The second one, unhepatic. To be fair, that one is completely last-ditch effort, and I've seen it here. There are a lot of liver transplants, but sometimes people delay to have a liver transplant, and therefore, in the event again of significant liver failure with multi-organ dysfunction, the dying liver is literally removed and not returned until they get a new liver. It buys them about 72 hours, but during that time, actually, the vasoplagia, the capillary leak syndrome reduces. And this underscores the point of the liver having the highest number of macrophages in the whole body. They're about 20 billion. So once it's dying, the macrophages recognize it as immune mediators, and it is basically activated and it shuts off the whole body. And that's why there are these last-ditch efforts. Thank you.
Excellent information. Thank you very much, Dr. Pritch, for that. All right, do we have any other questions? Any more questions, team? All right, so Dr. Halima, thank you very much for that presentation. So for now, I would like to proceed to the next speaker. Our next speaker is Dr. Patricia Kagola. She's an R3 emergency medicine student at Makerere University. She is going to take us through the interaction between the kidney and the lung. So over to you, doctor. Share your slides right away and start.
Good evening, everyone.
Good evening. There's a bit of interference with your sound. Try again, doctor.
Sorry, just a minute. Good evening. Is it better?
Dr.
Is it any
Kagola, I'm not
better?
sure which device you're using for sound, but we cannot hear anything. One of them is muted, one of them is unmuted.
Okay. I might request somebody to help in sharing because my computer has an issue with audio. So that's why I'm using two devices. Will that be in order?
Dr.
Hello?
Kagola, are you there?
Good evening once more.
Good evening, doctor. Please proceed.
Sorry for that. My computer has an issue with audio. That's why I'm using two devices. I don't know if I'm clear now.
There's a little bit of echoes, meaning that maybe there's interference in the internet, but please proceed.
Or if it is a challenge, I might request somebody to help in sharing because I'm using two devices.
It's all right, doctor. We can see your slides nicely and can hear you now.
Okay, my name is Dr. Patricia, and I'm going to take us through lung-kidney interactions. Yeah, and this is my outline. So we'll go through introduction. And then after introduction, we'd like to understand the physiological interaction between the lungs and the kidney. Then we'll like to understand how mechanical ventilation leads to acute kidney injury, and then how acute kidney injury leads to lung injury, and how chronic kidney disease also leads to lung disease. So in my introduction, it is important to understand that lung and kidney are closely related in function. And this is in normal physiology where there is no disease, and also in a diseased patient, the lung and kidney, their physiology is closely interacted. So in critically ill patients, we'll have either the lungs or the kidney or both of the two are always involved. And in patients who require mechanical ventilation, the fact that they require mechanical ventilation, patients who have AKI, the mechanical ventilation in itself is an independent risk factor for AKI development. While at the same time, having AKI also doubles the risk of a patient getting respiratory failure and as a result requiring mechanical ventilation. So in the physiological and molecular interaction of the lung and the kidney, there are a number of concepts that we need to understand. One is the immune response, and then phosphate metabolism, hormonal imbalance, acid-base balance, fluid dynamics, and oxidative stress. So under immune response, there are a number of cytokines that are produced in both the lung and liver, the lung and the kidney. And this will result in a number of pathophysiology that you're going to talk about. So some of the cytokines, we have pro-inflammatory cytokines like interleukin-1b, interleukin-6, and tumor necrosis factors. These cytokines are found to be elevated in chronic kidney disease. And we understand that in chronic kidney disease, we have reduced glomerular filtration rates and also impairment in excretion.
We cannot see your slides moving.
They are not moving?
Yes, kindly press the slideshow button so that it moves on the screen. We are still on slide 2.
Is it moving from your end?
Not yet. You may have to close and just reopen.
Okay.
You may not have you have not shared the slideshow. You have shared the PowerPoint itself.
Okay, just a minute.
Okay. Okay, that is better. Thank you. Kindly proceed.
Okay. So just a recap, the physiological and molecular mechanisms of lung kidney injury, we have a number of factors. And I talked about the immune response where we have pro-inflammatory cytokines like interleukin-1b, interleukin-6, and tumor necrosis factors, which are found in both the CKD and in a number of lung diseases like COPD. So these cytokines, they are found in CKD, and we know that in CKD we have reduced glomerular filtration rates and impairment of excretion, and as a result we'll have an increased circulation of these cytokines, which may end up being deposited in the lung alveoli, and this regulation will contribute a lot to development of a number of chronic lung diseases like COPD, asthma, and lung fibrosis. And then still in immune antibodies, we have antiglomerular basement membrane disease, which is an immune overactivation in both the renal and the lung system. Here we have antibodies, that is IgG antibodies, IgG1 and IgG3. They are produced against basement membranes of type 4 collagens. And these antibodies will attack glomerular capillaries in either the kidney and in the alveolar. in the kidney, we'll have glomerulonephritis, while in the alveoli, we'll have pulmonary hemorrhage. And then another immune disease resulting from antibodies and affecting both the lungs and the kidneys is antineutrophilic cytoplasmic vasculitis, cytoplasmic antibody-associated vasculitis, which involves both the lung and the kidney, and it has a significant morbidity and mortality. So in this disease, there is a complex interplay of immune response between the endothelial damage and inflammation, and as similar to the previous disease, anti-glomerulonephritis basement disease, will have antibodies being deposited in either the alveoli, capillaries, or in the glomerula. And we can have interstitial lung diseases and fibrosis in the lungs, and in the kidney, we'll also have glomerulonephritis. So another physiological factor that plays in these two organs, that is the lung and the kidney, is phosphate metabolism. And in phosphate metabolism, we understand that phosphate metabolism, generally, the regulation is either through GI2 reabsorption, it can be bone metabolism, or kidney excretion. And there are three modulators that are involved. That is the 1,2,5, that is vitamin D, the parathyroid hormone, and then we have the FGF23, which is follicular growth factor 23, and it plays a chief. It is the main modulator among these three modulators. Whenever we have increased phosphate intake, which is an occurrence in CKD, the FGF23 will reduce the circulation of vitamin D, and that is why we see vitamin D in CKD. We have low vitamin D, and there is a clear evidence that when we have low vitamin D, it is inversely related to COPD risk, severity, and exacerbation. And then another factor is fluid regulation. And here we understand that the main organ that is involved in regulating extracellular fluids in our body is the kidneys. However, the lungs are also involved. And this is evident, especially when you have patients who are hyperventilating. We understand that we lose a lot of extracellular fluids. So when we have patients with CKD, there is reduced glomerular filtration. And as a result, we'll have now increased circulation of the volume circulating is increased. So this may be deposited in the respiratory system, that is in the lung, and it will be evidenced as fluid overload, that is pulmonary edema. So still, when you have increased circulation volume in the lungs, you might end up having constructive obstructive disease or restrictive pulmonary dysfunction in addition to the pulmonary edema. And then there is syndrome of inappropriate ADH hormone secretion. We understand that ADH is secreted in the hypothalamus, and it regulates osmotic balance, BPs, and kidney functions. In normal beings, ADH will be produced in response to low blood volume and increased osmolarity. However, there are lung conditions that will result in inappropriate production of ADH, and these are conditions like pneumonia, asthma, respiratory failure, and patients who are mechanically ventilated with also pneumothorax will have these ADH being produced inappropriately, and this is now independent of osmolarity or blood volume, and it will also result in imbalance in fluid regulation. And then still want to understand the disruption in acid-base balance which affects both the two organs, that is the lung and the kidney. We understand that for the cells on the body to work well, we need a pH of between 7.35 and 7.45. But we have at times where we have pathologies that will result in either acidosis or alkalosis. And it is the lungs. If it is the lung that is affected, we always find that the kidneys are trying to compensate and the other way around. So we find that there is interaction is key in severe lung diseases, especially patients who have mechanical ventilation and they already have this disruption. If we have improper ventilation settings, we can exacerbate the acid-base imbalance. So it is good to understand your patient's acid-base status as you are trying to ventilate these patients. So the bicarbonate is directly result in alkalosis if we have it increased, while the partial carbon dioxide will result in acidosis. So in patients who have COPD and they have the acid-base balance, we need to understand there are other things that will accompany these patients, like that is they'll have malnutrition, muscle wasting, and even renal issues, which may further compromise this acid-base regulation if not taken care of. And then we'll also want to understand blood gas disturbances will affect both the kidney and the lungs. How does this happen? You understand that the kidneys are highly sensitive to hypoxic, especially in the glomerulars during the functions of one of the functions of the kidney is the reabsorption of fluids and electrolytes, and they use a lot of oxygen. So whenever we have a hypoxic injury, the kidney is highly sensitive, and that is when will result in conditions like acute kidney injury. At the same time, systemic hypercapnia can be experienced when you have lung diseases, and this will result in increased need for bicarbonate reabsorption in the kidney and the regeneration also of the bicarbonate to try and compensate the hypercapnia. Yeah. So the last physiological process that involves both the two lung and kidneys is the oxidative stress, where we have the lung being involved mainly in the exogenous sources of oxidative stress factors like cigarette smoking and ozone exposure, while the kidney mainly its sources of oxidative stress exposure are inflammation, ischemia, and immune cell activation and aging. So the lung is susceptible mainly to the exogenous free radical sources, while the kidney will be vulnerable to the endogenous. And this may result in either restrictive lung dysfunction, DNA damage, pulmonary oxidative stress, and fibrosis have also been shown to be associated with kidney injuries. So after going through the physiology, the other thing we wanted to understand is how mechanical ventilation will lead to acute kidney injury. And like the previous presenter, mainly Dixon, had talked about when we are having mechanical ventilation, here we have positive pressure as compared to normally where we are having negative pressure ventilation. So in positive pressure ventilations, what occurs, we'll have decreased renal perfusion as a result of, we'll be having increased central venous pressure, which will also have a decreased cardiac output. And these put together will result in prerenal acute kidney injury because of hypoperfusion of the renal cells. And then the neurohumoral pathway is also mechanical ventilation. When you are having mechanical ventilation, we'll have increased ADH being produced, decreased ANP. The RAS will also be activated with sympathetic activation. All these will work towards vasoconstriction of the renal vasculature, and as a result, we'll have hypoperfusion to the kidneys, also leading to acute kidney injury. And then the third mechanism is biotrauma due to ventilator in this lung injury. And this one may cause inflammatory mediators, being some of the inflammatory mediators I think we had talked about initially, the interleukins. From the biotrauma due to the ventilator induced lung injury, will have inflammatory mediators being deposited to the alveoli. And that is interleukin 1B, interleukin 6, 8, tumor necrosis factors, in addition to endothelial activation and microvascular dysfunction. When we have these cytokines in the lungs, they can also, through the vascular system, they can also be deposited in the kidney and result in acute kidney injury. So still on mechanical ventilation, this is just an emphasis on the previous slide on how the neurohumoral pathway will lead to acute kidney injury. And then the opposite can also happen. Now, acute kidney injury can also lead to lung injury. And how this happens, we understand that in acute kidney injuries, we'll again have cytokines, the pro-inflammatory cytokines being released. And these pro-inflammatory cytokines, as seen in the slides, get into circulation and can be deposited in the lungs, alveoli, and will cause injury to the alveoli. There is also damage associated molecular patterns. An example is mitochondrial DNA that also gets into circulation and deposited on the lung alveoli, will also contribute to lung injury. Also in acute kidney injury, we understand that we'll have elevated uremia, that is uremic toxins. If deposited in the lungs, will also contribute to acute lung injury. And when we have these patients with acute kidney injury and are on mechanical ventilation, the mechanical ventilation we had said also is a risk factor to acute kidney injury. These patients will get decreased lung compliance mainly because of fluid overload. There is also increased driving pressure and increased plateau pressures as compared to patients with AKI but who don't have fluid overload. So my last correlation is chronic kidney disease associated lung diseases. So here we want to understand how lung diseases are, that the chronic kidney disease associates with other lung diseases. The first disease is acute respiratory disease, that is ARDS. And this, from what we have gotten in the talk as we are going on, ventilation may result in pro-inflammatory cytokines being deposited in the alveoli, and as a result, you may have alveolar hemorrhage, vascular permeability from CKD. And then also from CKD, you can have bacteremia, that is bacteria from CKD, and uremia being deposited in the lung alveoli, resulting in weakened immunity. So for chronic respiratory diseases, these are diseases like COPD, asthma. We understand that we found out that in CKD, one of the mechanisms was phosphate metabolism. One of the mechanisms that was interacting between the two diseases was phosphate metabolism. And here we find that the FG, that is follicular growth factor 23, is high in circulation when you're having CKD, and as a result, we have reduced vitamin D. This, in combination, predisposes a patient to conditions like COPD, asthma, due to systemic inflammation in the lungs. And then you also have pulmonary vascular disease. These patients in CKD, they are predisposed to pulmonary vascular disease in a number of ways. So one of the ways in which they are predisposed is they have their coagulopathies. They have common coagulopathies, and this will lead to these patients having higher predisposition to pulmonary emboli. And then at the same time, there is increased RAS activation and upregulation of inflammatory response in these patients that will lead to pulmonary vascular remodeling in CKD. And this will contribute to these patients having pulmonary hypertension or worsening of the pulmonary hypertension if it was already there. Yeah, and then I talked of COPD and asthma, and we correlated that with hyperphosphatemia. Yeah. And in my take-home summary, from what we've discussed to understand the lung and kidney, they are closely correlated. Their correlation is very intertwined in that one organ, one person, or a patient can, critically ill patient can be having one organ that is affected, but in a process of management, you may induce the pathology on another organ from what we've learned. So it is good to understand lung-kidney interaction in the management of these diseases. Thank you.
Excellent. Thank you so much, Dr. Patricia. That's lovely. All right. So again, quickly, questions. Do you have any questions? I don't see anyone who has asked questions, but perhaps I would like to ask if you might have come across a phenomenon where patients with chronic lung diseases lose their sleep in the night because they have to wake up to pee so frequently in the night, but during daytime, they may not necessarily have the same problem. And maybe the explanation for it. It's just an academic one. We probably interact with the same in ICU, except that most patients in ICU are going to be put to sleep anyways, if they are to be intubated. But the question has a relevance to fluid and electrolyte balance.
That one I didn't come across. Maybe my mentor can help out.
Hi, yes. Thank you for that question. Yes, it's an interesting one. So if you think about it, when someone, so let's say someone has a significant pulmonary problem that has led to pulmonary hypertension. So there's already increased right heart pressures. There is carbon dioxide retention like in COPD. So there's vasodilatation. Now, when someone sleeps, physiologically, your respiratory rate goes down, and therefore, essentially, you become hypoxemic, literally. But because you don't require a lot of oxygen, the body deals with it and accepts it. But in these patients who already have a low reserve, if they become hypoxemic, the pulmonary vasoconstriction increases, and therefore the right heart function is actually more compromised. Basically, the right heart faces a higher afterload, and subsequently the right atrium will dilate more, and therefore it will lead to production of things like natriuretic peptide, and this will lead to increased natriuresis. Thank you.
Excellent. That is really good. And that's really where the thing is. So there are patients who have chronic obstructive pulmonary disease. who also developed cardiovascular disease. And as we know, the risk factor for the two seems to be common, and that's smoking. Many patients with COPD probably develop from smoking, and the smoking also may lead to atherosclerotic disease, which affects, which may cause ischemic heart disease. And then when they get heart disease and they go into heart failure because of ischemia, many times they are placed on a number of medications, including neprilysin inhibitors. Now, neprilysin inhibitors basically work by inhibiting the breakdown of natriuretic peptides. And so these people end up peeing a lot and also pushing out a lot of salt. And that might be able to help both conditions, the right ventricular function, in terms of reduce the preload, but also left ventricular function in terms of improving the preload. So something just to think about. You guys can read up the neprilysin pathway and its role in cardiovascular disease. And in this particular case, the lung, in terms of the stretch, the right atrium, right ventricle, which induces the release of the natriuretic peptides. Thank you. Any other questions, everyone? Maybe the other question, Dr. Pritch, since you were involved in the care of COVID patients back in the day, could you give a bit of an explanation for the differential metabolism of angiotensin in the setting of COVID?
Okay, thank you very much. So essentially, you should think about it as there are two enzymes. There's angiotensin 1, angiotensin 2. And essentially, angiotensin 1 is what is normally considered in the renin-angiotensin pathway. So essentially converting converting angiotensinogen to angiotensin. Yes, angiotensin 1, and then it helps with the metabolism. But in COVID, the SARS-CoV-2 virus itself was using the angiotensin 2 enzyme, basically, and the angiotensin 2 receptors to increase its penetration into the lung system. And that's where the challenge was. So angiotensin 2, so instead of angiotensin 1, it was targeting angiotensin 2, angiotensin converting enzyme 2 receptor to enter the lung, and that's where it was causing a big problem. I didn't see any trials trying to look at the effect of angiotensin converting enzyme inhibitors in this, because they're mostly targeting angiotensin 1, and also angiotensin receptor blockers, they're mostly targeting 1, but the challenge was with the angiotensin 2 receptor. Thank you.
Yes, so basically an SCE2 enzyme directs angiotensin metabolism towards Ang1 to 7, which is more of a vasodilator. And in that case, being a vasodilator meant that renal autoregulation would be altered. Similarly, pulmonary autoregulation would be altered, and which might explain why these patients would present with a relatively higher degree of hypoxemia versus the degree of lung injury that they had, perhaps because they had increased levels of Ang1 7. That is one of the hypotheses, certainly not tested. But I also, there were some trials where some people tried to not really trials per se, but like clinical experiments where people try to give angiotensin receptor blockers to try to improve lung physiology. And you're very right, it's actually a fail. In any case, there was worsening hypoxemia and worsening renal function in these patients. Perhaps again, because the ACE inhibitors are more sensitive. The ACE1 enzyme is more sensitive to these inhibitors than ACE2. And so blocking that ACE1 meant that we basically took away angiotensin 2, which is an important vasoconstrictor relevant to renal perfusion and also pulmonary autoregulation in a way. And as a result, these patients developed worsening renal intraglomerular pressures and went into renal failure a little bit more than others. At least these are a few observations that I found at least on the internet in terms of the cases people attempted to apply that physiology. It was just that people try to believe that the enzymes basically are the same. But if you understand enzyme physiology, the different types of enzymes lead to different metabolites. So important to note. Okay, thank you very, very much. And again, I hope these tidbits inspire people to go read up a bit more on the different topics and just understand a bit more how disease is. So finally, again, a very important subtopic to the theme that we are handling today of organ crosstalk. We are now going to the brain, and in terms of relating the brain to the lung and the lung to the brain, Dr. Benjamin Opio, who is a third-year resident and physician at Bishop University, will take us through the brain-lung interaction, and is mentored by Dr. Peter Agab. Over to you, Dr. Opio. Share your slides and start right away. Thank you. Dr. Benjamin Opio, kindly share your slides and start.
All right. Thank you very much, Dr. Erasmus. Good evening. I hope you're able to hear me.
Yes, doctor, we can hear you very well, and your slides look clear as well. Thank you.
Right. So I'm Benjamin Opio, and I'm going to present lung-brain interactions in critical illness. And my focus will mainly be on how the lung interacts with the brain and how the brain interacts with the lung in most of these illnesses, which we see in our ICU setting. So I'll look at mainly the biochemical, pathological, and physiological aspects of how these interactions happen, as we look at how it regulates respiratory function and the overall blood flow to the brain. That's the cerebral blood flow, and systemic homeostasis, which involves the inflammatory processes, which in the long run as well, or in the short run, affect the lungs due to the trigger from the brain injuries. In the synopsis of my presentation, we shall look at how neurological injury affects pulmonary function, the different elements of injuries we see in our setting, likes of stroke, subarachnoid hemorrhage, how they affect the lungs, the effect they have overall to the lung functions. And then we shall look at how pulmonary dysfunction causes effects to the brain. That's due to mechanical ventilation. And we shall look at also how hypoxemia, hypercapnia affects the brain and how it causes effects like changes in the intracranial pressure. Most of the parts of the ARDS has been discussed by Dr. Kamoga. So we shall look at some slight bit of it. So on how the brain injury affects the lungs, we shall look at mainly neurogenic pulmonary edema. And from the lung to the brain, we shall look at mainly ventilator-induced brain injury. But this should not limit your curiosity as you read through this topic through the literature, which I'll share as my reference. We shall also look at how hypoxemia induces neuroinflammatory processes and affects the permeability of the blood-brain barrier, increasing leakages due to formation of a lot of reactive oxidative elements. This image basically is to show you the interaction between brain injury and the effect it has overall to the lung. So usually when someone has severe brain injury, if they have an acute hemorrhage to the brain, subarachnoid hemorrhage, a stroke, usually there's a trigger of a sympathetic surge, which involves sort of a storm of release of catecholamines, which in the broad sense, when it reaches the vasculature of the lungs, causes increased vascular tone. And this as well leads to sort of increased permeability and leakage of fluid from the vasculature into the spaces. Now this is the mechanism of neurogenic pulmonary edema. On the bit of parasympathetic activation, it has been studied that stimulation of the vagus nerve can have a sort of protective effect in the sense that it increases activity of macrophages in the lungs, which can help in clearing of any infections. So that's one bit of area which is still being studied. We shall come back to this. And also different respiratory patterns can be in interplay, leading to asynchronies, which we usually see in overly sedated patients or in patients who have not had good settings of the ventilator, mainly in the ICU setting. So like I said, neurogenic pulmonary edema is basically as a result of massive catecholamine surge leading to pulmonary vascular permeability. So the fluid which we see in this kind of scenario is more of a transudate, like my colleagues had earlier on talked about. So common triggers in our setting are brain injury, subarachnoid hemorrhage, and then status epilepticus. So these need to be really managed aggressively because most of the times these patients are quite in a state of, they can be in severe pain. Status epilepticus can be quite painful. So we need to manage these conditions to reduce the likelihood of them progressing to needing respiratory support due to developing neurogenic pulmonary edema. The complications of neurogenic pulmonary edema could include, but not limited to, acute respiratory failure. We could have hypoxia and then airdius sort of like presentation. The possible features which we would see in a patient with neurogenic pulmonary edema could be coughing, frothy sputum, patient develops acute shortness of breath, tachypneic with distress features, the costal subcostal recessions, and if you do a chest X-ray, you could see features of infiltrates bilaterally, and if you do their ABG, they could be having features of hypoxemia. The most important investigations in these patients, since the diagnosis is more of an exclusion, you would want to do a chest X-ray, which you will see the features of infiltration. You would want to do an echo. This is mainly to rule out the cardiogenic aspect of which could lead to pulmonary edema as well due to left-sided heart failure. So you would want to do a cardiac echo to rule this out, to look at and rule out if there's any left atrial pulmonary, left atrial increase in size. This will help you to rule out cardiogenic aspect. So the management of neurogenic pulmonary edema is mainly supportive, which includes you managing the primary insult. If the patient has an injury in the brain, manage that. They need evacuation of the hemorrhage. You should do a decompressive craniotomy, manage the intracranial pressures, and also control of seizures in patients who are having status epilepticus. Use your benzodiazepines, or in this setting, if they're having status epilepticus.
Lost your audio.
Do you get me now?
Yes, it's clear now.
So you would want to control their seizures to manage this, and also to ensure they're having adequate oxygenation. If you can give them supplemental oxygen and monitor the requirements of their FiO2. If they need to be supported by mechanical ventilation, you need to intubate them, and also, but you need to use lung protective ventilation strategies like my colleague had mentioned earlier, the PEEP should be looked at, and then also the tidal volume should be well optimized. There's been sort of a controversial interplay between looking at whether to or whether not to use the beta blockers to control the effect of the catecholamines. But well, that's basically on, I think, patient to patient selection basis. So these are basically the brain lesions which could lead to, which can affect the respiratory drive of the patient. These can be lesions which can affect the brainstem, because we know that the brainstem basically is responsible for control of breathing, where the medulla is mainly having the dorsal respiratory group and the ventral respiratory group, which basically control the inspiration and the expiration respectively. And then in the pons, we have the pneumotactic center, which controls the rate and depth of breathing. So most of the lesions which affect these areas can cause significant effect on the breathing patterns. And the most significant breathing pattern which usually seen in these settings can be the chain stop breathing pattern, which involves episodes of hyperventilation, apnea, hypopnea, and then these cycles keep repeating within the whole episode. The X-tics basically are the same. You see episodes of increased respiratory rate, and then it keeps slowing down. Cycles keep repeating themselves, and the causes can be still the neurological diseases we talked about. Others could, which we've already looked at in the earlier aspects, like CVS disease, renal failure as well can lead to this kind of breathing pattern in these patients. And this can lead to significant hypoxia and hypercapnia in these patients, and eventually leading to acidosis. Now, also the ventilator in itself can have an effect on the brain, in a sense that when you're ventilating a patient, you do not want to give them very high FiO2s, because this can lead to hyperoxia, and hyperoxia in itself can lead to cerebral vasoconstriction. In the literature which I was looking at, they were looking at hyperoxia as being SpO2s of basically above 98%. So most of these patients you want to, that's why we set really quite low targets from about 92. So most of these patients, we want to keep them between 92 to about 98. Also putting them very high there can cause injury as well. So you need to titrate the amount of FiO2 you're using to ventilate these patients. Also, you want to avoid hypocapnia, which can as well lead to vasoconstriction, still leading to reduced cerebral blood flow. And you do not want to put very high intrathoracic pressures. The PEEP needs not to, in most of these patients, we are using PEEP, which should be well titrated, not to cause significant reduction on venous return, which can as well lead to increased intracranial pressure. So you need to titrate your PEEP as well in these patients carefully as you monitor the intracranial pressure. The risk factors of patients developing brain dysfunction secondary to ventilator is usually due to the mode of the ventilation, where they were looking at mechanical, the invasive type being more implicated, the duration the patient has taken on the mechanical ventilation, the amount of sedation and analgesia given the patient. So deep sedation has been implicated to worsen neurological outcomes. So most of these patients want to give them sort of light sedation and just control their pain to allow to reduce the effects of anxiety, which further triggers the catecholamine surge, which we talked about. So these are basically the prevention strategies. You want to minimize sedation. You want to encourage them to mobilize early and encourage rehabilitation also quite early. Ventilator settings, like we talked about, need to be optimized and monitor for any delirium, which you can manage with dexmedetomidine has been the drug of choice for most of these delirium patients. Non-invasive ventilation may not be appropriate in some of these because some of them are unconscious, so the non-invasive ventilation may not apply so much, but in some of them who can tolerate, you can consider. Okay, so we looked at already how hypoxemia can cause brain dysfunction. We are going to look at it now in details. So hypoxemia can lead to formation of neuroinflammatory cytokines, interleukin-1, 6, and tumor necrosis factor alpha. These in the effect lead to increased permeability of the blood-brain barrier, and this can worsen ICP due to increased leakage, and can lead to pulmonary and lead to cerebral edema as well. Hypoxemia can as well impair metabolism of different metabolites within the brain itself. The common causes in our setting for insults in the brain, like I said, are those subarachnoid hemorrhage, stroke, are the most common we see in our setting, and epidural. I would like to talk about also an element of silent hypoxia. This was first seen during COVID-19. I think Dr. Erasmus should throw more light on that, but it's just a feature where someone has very low saturations of oxygen, but they are not having shortness of breath. Now, most of the times this was seen in patients who are as well diabetic, and an element of autonomic neuropathy was implicated as the possible cause of this. So the patient is usually hypoxemic, but they are not in distress. And also most of them was seen to have normal levels of carbon dioxide. So that was the common feature in most of these patients. Okay, so how do we prevent hypoxemia in these patients? Early detection, keep monitoring the patients. Oxygen therapy, if you need to support the ventilation, not hesitate to initiate it early. Mechanical ventilation and monitoring of the intracranial pressure, and managing it in case you need to drugs, mannitol, hypertonic saline, and also neuroprotective strategies like therapeutic hypothermia. Yeah, so hypercapnia as well can have an effect on the brain because hypercapnia usually leads to vasodilatation of the cerebral blood vessels, and this can lead to increased intracranial pressure and cerebral edema, and also leads to reduced formation of these neurotransmitters like dopamine, serotonin, and acetylcholine. Hypercapnia as well leads to low seizure threshold, so we need to usually titrate and see that we do not have any episodes of hypercapnia, because these patients can potentially start to have seizures. So most of the times, patients who are having neurogenic pulmonary edema or lung injuries, we usually use if they're having pulmonary edema, you want to use a high PEEP with, but usually they also have a low compliance. And this kind of, if you're using a high PEEP in these patients, you can, you reduce basically venous return, and it can impair, it can lead to increment in the intracranial pressure in this patient. So we need to sort of watch how we, when we are ventilating these patients, we need to be watchful of the PEEP we are giving. Okay, so in most of these patients, we want to manage their intracranial pressure and also to maintain their PaO2, that's arterial tension of oxygen, at least above 60, and to maintain the arterial carbon dioxide levels to be between 35 to 45. That's the ultimate. That avoids any episodes of hypo or hypercapnia with all the effects we've discussed earlier on. And also you would want to optimize their PEEPs to balance oxygenation, like we've talked about. ARDS management was talked about by Dr. Kamoga earlier on, so this I'm going to just skip. But also you need to consider neuromuscular blockade in these patients who are having asynchrony. Like I talked about, one of the elements of brain-lung interplay could be asynchrony. So if you're having so much asynchrony, you could consider paralyzing the patients to allow adequate ventilation and oxygenation. For the COVID-19, we had already talked about. So the strategies basically we look at to ensure good goals for the patients in the ICU is to manage them with low tidal volumes of at least 6 meals per kg, and also titrating the FiO2 to ensure that oxygenation, the SpO2 is above 92. Like I said, we want to set the targets low to avoid also us giving to get hyperoxia due to use of high FiO2. In some patients, you can have permissive hypercapnia, but only if you've controlled the intracranial pressure. And also we can have a titration of the PEEP and lateral positioning. For the hemodynamic bit, you'd want to avoid excessive fluids because this can further worsen the hypoxemia, which usually presents in patients who have the neurogenic pulmonary edema. But as well, you want to prevent episodes of catecholamine surge by managing pain in these patients and getting anxiolysis. This will help you to reduce episodes of catecholamine surge. The most recommended drugs for sedation in these kinds of patients is propofol and dexmedetomidine, and that's pretty much because Dexmed has been shown to reduce inflammatory response of patients to mechanical ventilation. Benzodiazepines have been implicated to cause or to worsen intracranial pressure, so we are advised to avoid them in these kinds of patients. So what are the features you look at before you wean these patients off the ventilation? You would want to ensure that their mental state is good enough and your GCS is improving at least 10 to 12 and improving, good cough reflex and control of the upper airways reflexes as well. But also you need to plan for re-intubation because there's a risk of you re-intubating these patients because of a stridor post-extubation. You want to ensure that their FiO2 is greater than 200 and the intracranial pressure is less than 20. So this image basically shows us the interplay between the lungs and the consequences, but not every effect we see here is seen in every patient. But pretty much these are the effects we have: overstretching of the alveolar leading to cognitive impairment through the vagal signal direction. Not all these happen in every patient though. So this brings me to the last part of my presentation. Basically, what I wanted to bring or introduce us to is for us to know that the brain and the lung are in an interplay in ICU patients, and we need to be keen to see the effects we have between the hypoxemia, hypocapnia in the brain function in most of these patients, and also the effect we have on the intracranial pressure. And we need to also know that brain injury can cause secondary lung injury. So if a patient comes with severe traumatic brain injury, you need to look out for any features of acute respiratory failure, which could point you to neurogenic pulmonary edema, aspiration pneumonia, and ARDS. Thank you. That's the end of my presentation.
Lovely, Dr. Theo, thank you very much for your talk. So we should definitely quickly rush to the Q&A. So once again, I'd like to invite questions from the audience. Does anybody have a burning question to ask directly to Dr. Theo? You can just right away ask. All right, so Dr. Gerald is asking, give more light why benzodiazepines should be avoided because we use them a lot in sedation. The presenter, please proceed. Why would you recommend we avoid benzos?
Yeah, so benzodiazepines have been implicated to cause more increased cerebral vasodilatations, and that this can further worsen the intracranial pressure in these patients who are already having an insult to the brain.
Sorry, I don't know if it's my internet that is breaking or yours. Dr. Theo,
are you getting me? Hello?
I didn't get you there. You just give us your answer again.
Yeah, so from the literature I found, they were saying benzodiazepines cause increased cerebral vasodilatation, and this could further worsen the already raised intracranial pressure in these patients with severe traumatic brain injury. So that's why.
Okay, it's interesting.
And also it can lower the respiratory drive in these patients and can further cause hypercapnia, which can still have the same effect of cerebral vasodilatation and worsening the intracranial pressure.
So I imagine that difference is going to be down to the difference between how much it's going to drop the somehow the metabolism by protecting you against things like seizures and the like, versus how much it's going to vasodilate and increase blood flow to the brain, versus how it's going to impair your respiration. And I imagine respiratory issue is going to be less of a concern in a patient who is intubated and ventilated mechanically. Okay, thank you. The other question is from Dr. Preach. Say, thanks for the presentation. I have two questions. One, patients with epilepsy are at risk of sudden cardiac death, often while asleep. What's the most likely mechanism suggested? The hint is brain-heart-lung interaction. Do you have an answer to that?
I didn't get that. First,
patients with epilepsy. Patients with epilepsy.
Yes.
Are often at risk of sudden cardiac death, especially while asleep. What is the most likely mechanism?
directly, I haven't found that. Maybe if Dr. Preach can throw more light into that.
Is Dr. Gaba online, the mentor? Peter Gaba.
Hi, Erasmus. That was a trick
Yes.
question for who? For Pio. So Preach should give the answer.
Okay, again, apologies for the trick questions. So it's called SUDEP, a sudden unexpected death in epilepsy, SUDEP. Anyway, so the whole idea is that it is suggested that these patients get a seizure when they are asleep, and as a result of that, the epiglottis locks itself and they get hypoxemic, and as a result of that, they go into ventricular fibrillation and they die. Simple, that's it. Yeah, it's a trick question, apologies.
Yeah. Perhaps the other thing to consider is generally, depending on the kind of seizure, certainly, there may be people who might have a significant sympathetic storm to the cardiovascular system. And again, if they are sleeping and obstruct the airway, they're definitely having an increased metabolic drive of the heart. And in inadequate oxygen, they're definitely going to arrest quite quicker than in a setting where they probably were breathing. Yeah, quite a good one. And maybe the other question is around people who get false seizures, more like they actually having a ventricular tachycardia, and so they appear to be seizing, and then they collapse and die because now they're getting real cardiac arrest. And so the etiology of what exactly, or the trigger of what started everything can sometimes get missed. Someone might think it's a seizure that led to everything else, when it could actually have been as a cardiovascular problem primarily, leading to the cardiorespiratory arrest. Okay, second question from Dr. Preach, or is it a comment? He said, from the evidence, the recent trial, the TRAIN trial, suggests that the higher HB target in patients with acute brain injury, that's HB of 90 and above, 90 is grams per liter. I guess Dr. Preach will, in grams per deciliter, will be 9 and above. Why do you think a higher HB is better for patients with acute brain injury? Dr. Pio?
Yes.
Why do you think aiming for a higher HB, 9 and above, would be more helpful in acute brain injury patients?
Yeah, I would think it helps to increase the oxygenation for most of these patients. That's what I would think is the reason.
Okay, the oxygen carrying capacity and oxygen delivery to tissues might be better. Dr. Preach, is that in line with what you're thinking?
Yes, exactly. It's just oxygen carrying capacity, because if the brain is injured, there are normally watershed areas that are very sensitive to low oxygen levels. So if you have a higher hemoglobin, you have a higher oxygen carrying capacity, and therefore these watershed areas will be oxygenated. Well done.
Thank you. Perhaps the question now also comes down to the rheology, that there might be a cutoff beyond which the HP might end up being a problem, because now the blood will be too viscous to run through certain microcirculations of the brain. But I guess we don't know where that cutoff is yet, because in normal physiology, people actually have better blood flow, better HB, and that flows very nicely to their brain. I have two questions. One is regarding the respirophasic heart rate variability in brain death testing. Dr. Pio, did you come across anything to do with this in patients you assessing for brain death, looking at the heart rate variability with the respiration?
Dr. Rasmus, I didn't meet that in English. I was reading.
Okay. And then I guess Nava, just two things that maybe I'll just patch in Dr. Gaba quickly for this, then we shall conclude. Dr. Gaba?
What again are you asking?
Yeah, so the role of the respirophasic heart rate variability in brain death testing.
Okay, so
Nava in the care of the of the ICU acquired weakness patients?
All right, maybe I'll just start with NAVA, especially because I don't have much experience with it, but it's just a neurally adjusted ventilation, ventilatory assist, something like that. There's an electrode in the esophagus that detects activity from the diaphragm, and I think the idea here is that it keeps the diaphragm active and avoids atrophy of the diaphragm. I mean, this is something I think I remember from MMed. Erasmus will shed more light on that one. Now, the respiratory heart rate variability and brain death testing. Now, there is a normal fluctuation in the heart rate that occurs with the respiratory cycle, and it's primarily mediated by the autonomic nervous system, particularly the parasympathetic nervous system through the vagus. So in healthy individuals, there's an increase during inspiration and then a decrease during expiration. What is sometimes called the respiratory sinus arrhythmia. So in brain death, we expect that variability will go away, okay, because the brainstem, which is what controls it, is gone. So that regulation in heart rate is not there. So it is used as kind of additional evidence that someone is brain dead. It's however not just used alone. It's actually not even required, but you may use it as a something to give you to convince you really that the patient is no longer there. Yeah. Eras.
Yeah, that is sweet. Yeah, so I personally kind of just observe the variability of the heart rate when the patient is breathing in the ICU. And when I feel the tidal volumes are not exactly large enough, sometimes just okay, I just experimentally increase the delta P so that the tidal volumes they are taking are quite bigger. And like Dr. Peter mentioned that, when you breathe in, essentially your parasympathetics jump in through to respond to the afferent stimuli coming in through the G receptors, the stretch receptors, to stop you from inhaling so that you can switch to exhalation. That's the role of the vagal nerve. So while the outflow through the vagus nerve increases, it doesn't select. The vagal nerve also touches on the cardiovascular, on the right atrium, and as such, it slows down conduction. So you expect some sinus, arrhythmia with breathing. So when I have a patient with severe brain injury of any kind, and I'm having challenges, detecting the rest of the reflexes, it's one of those things that just adds to the data points that, the patient has no heart rate variability with respiration. I probably will go ahead and inject some atropine as well to them and see if their heart rate will increase. And usually it doesn't increase as well. So if there's no response to atropine as well, that kind of builds a very strong case of possible brain death in the patient. And in all honesty, I haven't seen a patient who lost heart rate variability with respiration and also had a negative no response to atropine, who came out somehow by some sort of miracle that they got healed. Actually, these guys were eventually confirmed brain dead through the standard brain death testing. So I usually use as a preamble to, or at least a prelude to building a case for a brain death testing for these patients. If you skip it, for now, really doesn't matter. I just like to use all the data points I see before the patient. NAVA, like Dr. Gaba mentioned, is a neurally adjusted ventilator assist. It's more of a winning mode of ventilation, or a mode that allows patients with ICU acquired weakness to maintain some level of neuromuscular activity of the diaphragm and the like, so that they don't lose their neuromuscular, they don't atrophy their respiratory muscles. So basically they're passing an esophageal catheter towards the lower esophageal sphincter, where basically the fibers from the diaphragm kind of cross to make the lower esophageal sphincter. So the idea is that an increase in the tone of the diaphragm is equivalent to an activation of the respiratory effort. Now, these weak patients many times are too weak to trigger the ventilator. So what NAVA tries to do is to read the signal of contraction of the diaphragm at the lower esophageal sphincter area, and depending on the threshold you've set, it detects us as a trigger to provide supportive ventilation to the patient. That way, a patient who is too weak to trigger a ventilator, even with a flow trigger of like 0.5, is not able to, may now be able to breathe spontaneously. And the more they breathe, the more they keep their respiratory muscles active, and that might help them to regain strength of respiratory muscles and eventually get wind. It's a specialized mode, which, as we get ventilators which can go lower in terms of flow triggering now, it's not exactly so much use, especially the fact that you have to insert a catheter into the esophagus and keep it in one place and keep getting this place as the person swallows, or or the reflux, so it's kind of a bothersome mode overall. But for patients who have been ventilator dependent, especially with the neuromuscular component, it has been found to actually optimize their ability to come off the ventilator over time, and especially to regain a synchrony with the ventilator. So that is really what NAVA does. Yeah, so thank you so much. We well past our time again, and we hope that we will be able to. Yes, sir. Go ahead.
Just before you go, there was a question about benzodiazepines.
Yeah, go ahead.
I'm not sure if that was covered, but briefly, the idea behind reducing them is that there is evidence that patients who are sedated will generally, or overly sedated, will generally do worse than those who don't, and that the more important thing probably is managing their pain than simply just sedation. And most clinicians will go for deep sedation because they want they want ventilator synchrony. But there's also some evidence that shows actually that that's not what happens. And instead you end up with these patients on the ventilators longer, and with lots of other problems like ICU weakness and so on. And yet, if you simply stuck with mostly some analgesics like morphine, which probably is better off, it has got some neuromodulatory effects. I think prevents release of interleukin 17. There is also, I think, dexmedetomidine also, which has been shown to have probably some good effects, and even propofol, which has got some neuroimmunomodulatory effects. So those are probably better sedatives than benzodiazepines. However, people just love midazolam. I don't know why, and despite all the evidence that is out there, we are more likely to keep our patients deep, even though we sometimes don't have to. Yeah, so that was the reason behind the caution about benzodiazepines.
Yeah, thank you very much. Perhaps the other thing that you've not added here is the issue of delirium, and exactly leading to what you just mentioned, the negative outcome versus the others. But I would also like to just add that almost any sedative will likely lead you to delirium. Maybe benzos are just a little bit more potent because of the amnestic effect they have on the patient, and therefore the patient loses a sense of time, place, and the person. And that drives out of delirium in them. And also the fact that benzos speak directly to the inhibitory pathway of the brain, allowing the stimulatory part of the brain to upregulate itself as well. So now by the time you turn off these things, the stimulatory side is not yet happy enough to go down. And so the patient gets this neurotransmitter overload and mismatch, which leads to delirium. All right. Thank you, team, for today. It's been a long discussion. Again, I hope that in future we shall start exactly on time. But this has been the Pulmo organ Higgy Hagga. We've at least appreciated what the lung plays as a central organ, causing dysfunction in the other vital organs, brain, heart, kidney, and liver, but also as a victim of disease in those other organs and how fast things can definitely go haywire and putting the patients in trouble. It is clear that things are interconnected, and like dominoes, sickness in one will definitely trigger sickness in others if you don't intervene. And our goal in care of these patients is to maintain a 360-degree view of the patient, assessing them beyond just the disease they are presenting with, and so that we can provide essential support that treats the underlying disease and sustains the other unaffected organs. So that's really the idea behind us as understanding the organ interactions between the lung and other organs. We shall soon be winding up Pulmonary Madness, and we shall definitely be looking at the lung in the perspective of the other organ failures as well. And we shall appreciate this a lot more and more. So maybe as we keep covering these topics, one thing that I hope we shall all appreciate is the fact that the body is so interconnected and so vulnerable, such that, one small thing can trigger everything else. But also that's the opportunity that the interconnectedness of organs means you can actually support the failing organ through supporting the other organs. And that makes critical care such a fun subject. So we've come to the end of this session. And so I would like to give you a sneak peek to the next session that will be held on Friday next week, same time. We shall be looking at the cryptic badness, or what I don't know what to call it, cryptic badness that haunts us in terms of lung disease. So kindly, again, go read up these cryptic conditions that affect the lung, affect the body, and tell a colleague also to prepare, and let us meet again to have fun on Friday. Thank you, and bye-bye.